An area where our program differed slightly than some of the other studies and programs you may see is that we had all new patients coming to our clinic that would enroll through this program, and so that included both new diagnoses and those who were ART naive, as well as those who were potentially transferring care or had fallen out of care somewhere else and were coming to us. The population we did not include were those who were re-enrolling in our clinic, so had previously been patients in our clinic and were re-enrolling. And so it did make it a little bit more complex in terms of the type of patient we were dealing with. It wasn't just a brand new patient, and it made the antiretroviral start process a little bit more complex. And so in terms of the study, we excluded all those patients who were transferring care that were on therapy or were virologically suppressed, because our goal was really to look at time from that first step in our clinic to when they became virologically suppressed. And so we compared we did a simple pre-post study. The pre-study, or the pre-group, ran from January through May 15th of 2016, and then the post group was from May 16th, 2016 through the end of July 2016. And within that 2.5-month period in the post group, we enrolled 90 new patients into our clinic. And so it's, again, a very large volume clinic, and very quickly actually overwhelmed our system in terms of both being able to get onto provider schedules, as well as those individuals in the system who were working to get them their antiretrovirals quickly when they didn't have a payer source. By making all the changes in the enrollment process, we were able to decrease the time from that first step in the clinic to their first clinic appointment from about 2.5 weeks down to 2 to 3 days. And the time from that first step in the clinic to starting antiretroviral therapy from over 3 weeks down to about 4 days as well, when it was adjusted for other factors such as age, race, and being antiretroviral naive. And then those process improvement changes really resulted in a decreased time to viral suppression, and we decreased the time to viral suppression from about 67 days down to 41 days. So that was statistically significant and remained significant again when controlling for some of the factors that we typically associate with not achieving viral suppression. What we did not find was a overall improvement in the proportion of individuals who achieved viral suppression. So in both groups it was about 70%. And unfortunately we're not able to prove it with empiric data, but anecdotally the reason we feel that that's the case is by making all of those changes to our enrollment process and the eligibility, we all of a sudden were getting people into care that were previously being turned away at the door. And that was never measured, all those patients that were being turned away, so probably a more difficult population to retain in care in general. And so I think this study really provided a proof of concept for other sites in the South that are under-resourced, that it can be done, but it is a heavy lift. And so I think we need to advocate for additional funding to target these hard-to-reach populations and get them into care more quickly. And I also think studies moving forward, we really need to define exactly which population will benefit from this approach the most. Ideally, I think we do it for all, but because of the limited resources, it may be that we have to triage which populations really come into care this way.